Welcome to the stage Dr. Ezekiel Emanuel, Vice Provost for Global Initiatives, Co-Director of the Health Transformation Institute, University of Pennsylvania, with the Hills, Julia Manchester.
Dr. Emanuel, thank you so much for taking some time out of your busy schedule to be with us today. We appreciate it.
My pleasure.
So you authored a report with the COVID Crisis Group titled Lessons from the COVID War. I'd like to know what some of those lessons are, and are you satisfied with how we're applying those lessons now?
Well, the short answer to the last question is no. And I think, we're going through our usual habit in America of crisis, respond to the crisis, and then forget it. And this is a conspiracy of the public, politicians, businesses, right? Everyone wants us to forget. Why do they want us to? We like it in the rearview mirror because we want to get back to normal. Politicians don't want it because it's not good for them. Businesses don't want us to focus on it because it wasn't good for business. And that just makes me really worried, and our group really worried about the future, because we're not going to invest in the infrastructure we need to really address the underlying public health issues, build up public health departments throughout the country in a sustainable way, get the data in real time to Atlanta so we can have real-time data analysis the way they do in Israel or Britain or Denmark or Singapore, so you can actually figure out what's going on. Having a very comprehensive monitoring system. The CDC is putting out an RFA for wastewater monitoring, but it's going to be, I think, relatively constrained, and we need a very comprehensive one. Infectious organisms. We also need monitoring of drugs in the wastewater. We need development of next generation, not just vaccines, but a whole series of interventions. And I don't think we've done enough to sustain our market for things like masks, PPE, et cetera. We had this big explosion of innovation and production, but then they're slightly more expensive than what you can import, and we go to the cheap instead of the sustainable in the country. So the short answer is I'm not optimistic about the future, unfortunately, and it looks like we're not going to end up with an assessment of what we did and what we could do better, the way other countries are doing.
And do you think part of that is because it seems, across the world, but particularly here in the US, there seems to be this urgency to move on from COVID, which understandably, but maybe there's not being enough time taken to reflect and to dive into what we did wrong during COVID and what we can improve on. Is that a concern for you?
Yes, it's always, I think it's very characteristic of American responses to crises, and I don't think it's a good thing. And we know that from COVID, that countries that took the lessons of SARS in the early 2000s, Taiwan, Japan, South Korea, all the countries around China, they did better initially. And they did better because they had taken the lessons. They had built their public health infrastructure. They had built a monitoring system of what's coming out of China. And I think those are very important elements of infrastructure. And, I think for the last 40, 50 years, we've underinvested in all sorts of infrastructure, public health infrastructure, pretty close to the top.
Right. And, you talk quite a bit about cancer care and access. How did the pandemic impact that? I had a close friend who had cancer last year, and she was talking about how, it was just a completely different, if she hadn't gotten cancer prior to COVID, it would just have been a different experience.
Well, that is right. So one of the things that COVID did on the bad side is a lot of people didn't want to go in and get screened. And we know that has had an effect. On the good side, it actually led to some innovations, and here I'll advertise for my institution, the University of Pennsylvania. One of the things we did, I had nothing to do with this, so no conflict of interest for me, we actually began giving chemotherapy at home. Now, when I was training 30 years ago, and someone said, you're going to give chemotherapy at home, especially of these pretty toxic drugs that cause a lot of nausea and vomiting and other things, I would have said, you're detached from reality. You need some behavioral health intervention. But now we gave thousands, tens of thousands of courses of chemotherapy at home. And that's, I think, a huge positive innovation that was forced on by COVID. And I think that's really a major improvement going forward. The problem is, as all of you know, we're facing this huge issue of shortage of regular generic drugs now because COVID has exacerbated it because of production lines and things in China and India mainly. And I have a lot of people calling me up, I need cisplatin, my oncologist can't seem to get it, how do I get it? That's a problem we do actually know how to solve. It is an infrastructure problem. It's also a national security problem. We should not be dependent upon other countries for vital drugs. And it's gotten worse. I mean, when I left government in 2011, my very first op-ed is, we're rationing cancer chemotherapies. That was 2011. We're still doing it 12 years later. We haven't addressed this problem. I'm hoping that the attention that COVID and now the post-COVID moment has focused on this problem will finally get us to move on multiple fronts. We need to really monitor the production quality. We need to onshore or nearshore production. That's going to require some investment, just like the CHIPS Act. And this is important for not just the United States. It turns out these shortages are worldwide because we have all focused on the cheapest production again, instead of resilient production where we can monitor, inspect those facilities, make sure they're following good manufacturing protocols, et cetera. I'm hoping one of my real is we can actually solve that, address that problem in legislation and solve it so that 10 years we don't come back and say, well, we're still having those shortages requiring us to ration basic things like generic chemotherapies.
So does that process of not relying on outsourcing drugs begin with legislation, or does it begin somewhere else? How do we get on that track?
Given the economics, it's going to have to begin with legislation. So the economics, again, is let's go to the cheapest. So you ask hospitals or you ask oncologists, what do they want to source? They want to source the cheapest. Well, that, the cheapest may not be the best from a quality standpoint, and we can see that. But we also need to have a domestic production. And when you go to certain countries, they are very focused on, buying their own. I was just recently in Japan, and you go through stores there and they say, made in Japan, and they're very proud of it, and they insist this is the highest quality. I think we have to get some, I remember that when I was growing up, we have to get some of that back. We have to have domestic or nearshore production in our allies where we can share. It's very, very, I think, important. And again, we think about this in access to antibiotics. This is also national security. We need those drugs for our soldiers. We need those drugs for their families. If we have to not be dependent on countries where we're having, ongoing tense relationships with, and we don't know where it's going to go. And I think that domestic production also allows us more FDA inspections, more clear access. And by the way, it's not just drug production, it's also the active ingredients, the chemicals we need for many of these need to be onshored.
I think I may know the answer to this question, but do you get the impression that this is a priority for legislators in the administration right now?
Yes, I think the public being so upset about these shortages and the persistence of these shortages. They just weren't a flash in the pan and it was solved, that has made, I think, a lot more attention to this. And I also think this administration, their signature issue in healthcare has been drugs, drug pricing, drug access, and eliminating a lot of the disparities. And I think this fits nicely in that agenda.
Yeah, and we've talked a lot about your concerns with these issues, but what's the number one thing with healthcare that keeps you up at night? Open-ended, I know.
I would say, so the near term is the system. One of the things we saw with COVID is how rickety parts of the system were, how easy it was to overwhelm the system, and we kept talking about we need to flatten the curve so hospitals don't become overwhelmed. Well, the fact is that hospitals today and that part of the system are really teetering economically, burnout from lots of staff, lack of staff in critical areas, and I think it's not going to take much to really create a crisis in the hospital sector. And that actually, I think, the public, politicians, policymakers don't appreciate how tenuous that situation is. 3 years of COVID has really taken any resilience out of that part of the system. And so I think it keeps me up at night that we need a really bad flu season could really knock us off. On the longer term, the real problem, I think, is our system is overly fragmented in every way. We've got this, and the last panel was talking about, access for Medicare people versus Medicaid people versus commercially insured versus the VA versus, we should not have that, right? We've got different prices in all those areas. We've got fragmented delivery systems, so the primary care doctor doesn't talk to the specialist, so they don't coordinate. No one's incentivized to do that. And I think we don't have a good way of actually reforming that kind of problem. And that's a long-term problem that is only getting worse, not better. And every solution we add, and here I plead guilty, we added solutions during the ACA. They did a lot of good, right? We got 22 million people insured, et cetera. But we also made the system so much more complicated, and it added another fragmented element to it. And that fragmentation in the end is weighing down on the system. And I don't see people focusing enough on how to solve that problem. We're great, and I think actually we didn't talk about some of the great advances. We have made some serious advances in making parts of the system better. Virtual care, care at home, and things like that. But the whole structure of the system remains totally broken, and we're not making any progress in really trying to fix that. We have too many interest groups who are still making money, but I don't know. If I took a poll here, I'm willing to say that 95% of the people here are not happy with the healthcare system and are frustrated. And you are the privileged in our society. And when that's true, there's a serious underlying problem. That underlying problem is what's keeping me up at night on a long-term basis, and something I'm trying to think through. How do we solve that underlying structural problem in a politically feasible way?
That's certainly something to think about. Dr. Ezekiel Emanuel, thank you so much.
Thank you.